If you have ever, helped a parent or a grandparent manage their health, you have probably found yourself just staring at one of those massive 7-day pill organizers.
Oh, yeah, the really heavy plastic ones.
Right, the ones that are roughly the size of a computer keyboard,
Yeah.
with the little compartments snapping open for like morning, noon, evening, and night.
Yeah.
And if you've ever looked at that whole rainbow of pink and white and blue tablets, you might have caught yourself wondering, how does one single body process all of this chemical information at the exact same time?
It's a really striking visual, honestly, when you see that pill organizer sitting on a kitchen counter. It looks like a miniature personal pharmacy.
It really does.
And we've kind of normalized it, right? But that everyday piece of plastic is actually hiding this incredibly complex, largely invisible biochemical balancing act that's just, well, happening right beneath the surfing of the skin.
And navigating that balancing act is exactly our mission today. Welcome to your custom deep dive. Today, we are taking a stack of medical history, pharmacology principles, and some major clinical studies to really unpack the science of geriatric pharmacology.
Yeah, with a huge focus on polypharmacy and the older adult.
Exactly. We want to understand how the aging process fundamentally rewires the way a body handles medications. Like why standard, seemingly safe doses can suddenly turn dangerous. And why the real problem isn't necessarily the sheer number of pills in that organizer, but the hidden physiological changes taking place inside the person who's actually swallowing them.
Yeah, and to really grasp the scale of those hidden changes, I mean, we first have to look at the history of how the medical field viewed aging in the first place, because the understanding we have today is surprisingly recent.
It's wild. The history here is actually fascinating because the term geriatrics didn't even exist until, what, 1909?
1909, exactly. It was coined by an Austrian-American physician named Ignaz Leo Nasher.
Nasher, right.
Yeah, and he basically looked at the medical field and argued that, hey, if we have pediatrics for children, we desperately need a dedicated specialty for old age.
Which makes total sense.
Yeah.
But the broader medical establishment was pretty slow to adopt the actual pharmacological implications of that, right?
And incredibly slow.
Yeah.
For a very long time. I mean, throughout the early and mid-20th century, a lot of doctors essentially treated old age as if it were a diagnosis in and of itself.
Like someone walking into a clinic and the doctor just saying, well, you have a severe case of being old. Let's give you some medicine for that.
That is, unfortunately, very close to how it operated. Because old age was viewed as this blanket condition, drug dosing for elderly patients wasn't tailored much at all. Doctors were handing out the exact same standard adult doses they would give to a healthy 35-year-old.
Wow.
Yeah.
Yeah.
It really wasn't until the 1960s, stretching into the 80s, that clinical pharmacologists started sounding the alarm.
Because they were seeing actual harm being done.
Right. They were seeing this wave of troubling case reports. Older patients were being severely oversedated, ending up hospitalized, or even dying from doses that were considered, completely safe for younger adults.
So they realized that standardizing a dose based just on being a grown-up was fundamentally flawed.
Yeah.
It sounds like they started to understand that aging isn't just one uniform decline.
Exactly.
Like your liver might be slowing down, but your gut might be totally fine, and your kidneys might be operating on a completely different timeline.
And that realization birthed this massive debate in the field that is actually still ongoing today.
Oh, really?
Yeah, the core question is, how should we define who actually needs geriatric pharmacology? Do we base it on chronological age?
Like just looking at their birth year.
Right, like drawing a hard line at age 65, which, by the way, is still the cutoff most clinical trials and medical guidelines use.
Mm-hmm.
Or do we base it on physiological age and frailty?
Measuring actual physical decline.
Yeah, things like grip strength, how fast a person walks, and the actual reserve capacity of their organs.
Thinking about this, I keep coming back to a used car analogy.
Oh, I like that.
Right. Because imagine you have two cars sitting in a driveway, and both of them are exactly 10 years old. Their chronological age is identical.
Okay, yeah.
But one of them has been kept in a climate-controlled garage. It's only driven to the grocery store on Sundays and gets regular oil changes. The other car has been used as a city taxi for a decade. It's hit every pothole, idled in traffic, and been driven hard every single day.
Right, so the chronological age is 10 years for both, but the mileage is completely different.
Exactly. The actual wear and tear on the suspension and the engine is completely different. If you're a mechanic, you don't treat those cars the exact same way just because of the year they were manufactured.
That analogy perfectly captures the consensus of modern geriatricians. I mean, they argue that two 78-year-old patients can have wildly different drug handling capacities based purely on their life's mileage.
So when we talk about geriatric pharmacology, what we are really talking about is frailty-adjusted pharmacology, right?
Yeah.
It just happens to wear an age label for the sake of convenience.
That's exactly it.
Okay, so if we accept that two older adults can have totally different mileage, we kind of have to look under the hood to see what is actually wearing down.
Let's do it.
Let's talk about the mechanics of how these aging bodies are processing chemicals differently, because the sources break this down into pharmacokinetics and pharmacodynamics.
Right, those are the two foundational concepts. Pharmacokinetics is simply defined as what the body does to the drug, and pharmacodynamics is what the drug does to the body.
Got it. Let's start with pharmacokinetics. What the body does to the drug. There are 4 steps here, right? Absorption, distribution, metabolism, and elimination.
Correct.
And interestingly, the research notes that absorption is like the least affected by age.
Yeah, it's surprising. The gut is remarkably resilient and keeps absorbing pills pretty efficiently well into old age. But the next step, distribution, is where things start to really change dramatically.
Because of body composition changes.
Exactly. The way a drug distributes itself throughout the body is heavily dependent on body composition. As human beings age, a very predictable shift happens, even if their weight on a scale never changes one bit.
Oh, wait, really? Even if their weight stays the same?
Yeah. They typically lose total body water and lean muscle mass, while their proportion of body fat increases.
And that ratio change is a really big deal for drugs that are lipophilic, right? Meaning they are fat soluble.
Yes, exactly. The classic example in the medical literature for this is diazepam,
which is a pretty common benzodiazepine, usually prescribed for anxiety or to help someone sleep.
Right. Diazepam is highly fat-soluble. Because an older adult has a proportionally higher amount of fat tissue, the drug has a much larger area to dissolve into. In pharmacology, we call this an expanded volume of distribution.
Okay, let me see if I have the mechanics of this right. Imagine taking that dose of diazepam and dropping it onto a sponge. In a younger person, it's a relatively small sponge. But in an older person, because of that increased fat tissue, it's a massive sponge.
Right.
So it soaks up the sedative deeply, and instead of clearing it out quickly, it just slowly drips it back into the bloodstream over a long period of time.
The sponge is a highly accurate way to visualize it. I mean, in a younger adult, a dose of diazepam has an effective half-life of roughly 1 day. They take it, they sleep, they wake up, and their body clears it.
Just a normal night's sleep.
Yeah. But because of that massive sponge effect in the fat tissue of an older adult, the drug gets sequestered and released so slowly that the half-life can stretch to several days.
Wow, days.
Days. You could give an 80-year-old patient a dose on a Monday evening. They sleep fine. Tuesday, they seem totally okay. But by Wednesday or Thursday, that slow drip is still happening.
Oh my God.
And suddenly they're dangerously drowsy, their balance is off, and they are extremely prone to falling.
That is terrifying. So they're experiencing the peak danger of a sedative days after they took the pill, when the doctor and the patient aren't even thinking about the drug anymore.
Exactly. And the consequences are severe. There are these epidemiologic studies by researchers like Wayne Ray that have drawn a direct, measurable link between benzodiazepine use in older adults and a sharp increase in hip fractures.
And it's driven by that delayed, slow drip mechanism.
Almost entirely.
Okay, so that covers the fat tissue holding on to the drug. But eventually, the body has to break that drug down.
Right, which brings us to metabolism.
Which is basically the liver's department. Does the aging liver struggle in the same way the body's fat composition does?
It does struggle, but in a very specific way. As we age, the physical mass of the liver shrinks, and the blood flow to the organ actually decreases. This reduces what we call first-pass metabolism, which is just the liver's attempt to filter a drug before it circulates to the rest of the organs. But here is the fascinating part. The liver actually uses 2 different systems to clear drugs, known as phase 1 and phase 2 metabolism.
Yeah, the sources mention those phases, but they get highly technical really fast. Can you explain how those 2 systems actually work in plain English?
Sure. Think of phase 1 metabolism as the liver trying to just burn the drug down.
Burning it down, that's
Right.
all.
It uses a process called oxidation, which is powered by a family of enzymes known as cytochrome P450. It's a harsh, active process.
In phase 2.
Phase 2 metabolism, on the other hand, is more like attaching a heavy molecular backpack to the drug.
A backpack.
Yeah, this is called conjugation. The liver tags the drug with a water-soluble molecule so it can easily get flushed out in the urine.
Okay, so you've got burning the drug down versus strapping a backpack to it so it gets flushed away. How does aging affect those two distinct systems?
Well, the enzymes responsible for the burning process phase 1, they get incredibly sluggish as we age. They lose their efficiency.
Okay.
But the backpack system phase 2 conjugation stays remarkably robust, even in advanced old age.
Really? That seems like a massive advantage if you know how to use it. Like if I'm a doctor prescribing a drug to an older patient, wouldn't I want to just choose a medication that skips the sluggish burning process and go straight to the backpack system?
That is exactly what smart prescribers do. There is actually a helpful mnemonic in geriatrics for prescribing sedatives. It's the LOT drugs.
LOT. Okay. What does that stand for?
Lorazepam, oxazepam, and temazepam. These specific medications bypass the sluggish phase 1 system and rely heavily on phase 2 metabolism.
Oh, wow.
Yeah, because the phase 2 system is still strong, the doctor can predict exactly how long the drug will stay in the patient's system. They completely avoid that dangerous slow drip effect we saw with diazepam.
So you can outsmart the aging liver if you just know the mechanics of it.
In-
But if the liver manages to package the drug up, with the backpack, it still has to be escorted out of the body.
Right.
And that leads us to the kidneys. Looking at the sources, this seems to be one of the most dangerous blind spots in all of medicine. Let's dive into what they call the creatinine trap.
This is a big one. So the kidneys are the primary organs for drug elimination. We measure their efficiency using the glomerular filtration rate, or GFR, which is essentially just a measure of how fast the kidneys can filter blood. The biological reality is that after age 30, GFR drops by roughly 1% every single year.
Okay, so it's a steady, predictable decline for everyone. But if the kidneys are slowing down, how do doctors normally measure that decline in a routine checkup?
They run a standard blood test to look for a chemical called serum creatinine.
And this is where the trap is hiding. I want to make sure the mechanics of this are crystal clear for you listening. Where does creatinine actually come from?
Creatinine is a natural waste product generated by your muscles. Simply by moving, walking, just existing, your muscle tissue produces creatinine. It enters the bloodstream and gets filtered out by the kidneys.
Okay.
If your kidneys are failing, they can't filter it out, so the level of creatinine in your blood goes up. A high creatinine number tells the doctor the kidneys are in trouble.
But earlier we established that as people age, they lose lean muscle mass. Sarcopenia.
Exactly.
If an older patient has significantly less muscle, they are producing significantly less creatinine to begin with.
That is the mechanical trap. You could have an 80-year-old patient with kidneys that are functioning at, say, 50% capacity. But because they have very little muscle mass, they're only producing half the normal amount of creatinine anyway. Yeah. So when the doctor looks at the lab report, the creatinine levels appear perfectly normal.
Wow. So a totally normal lab result is essentially lulling the doctor into a false sense of security. The lab says the kidneys are fine, but in reality, they are failing, and the lack of muscle is just masking it.
It is entirely masking it. This is why geriatricians stress that clinicians absolutely cannot rely on raw creatinine numbers for older adults. They have to use age-adjusted mathematical formulas like the Cockcroft-Gault equation.
Which factors in the age and the weight?
Right. It factors those in to estimate their true kidney function. If a doctor just trusts the raw number, they will almost certainly overdose the patient.
The sources gave a harrowing example of this involving a heart medication called digoxin.
Digoxin is the classic example here. It's used to treat heart failure and irregular heartbeats, but it has a very narrow therapeutic window.
Meaning the line between a helpful dose and a toxic overdose is incredibly thin.
Incredibly thin. And crucially, it is cleared from the body almost entirely by the kidneys.
I can completely see the domino effect here. The doctor looks at a normal creatinine lab, assumes the older patient has the kidney function of a young adult, and prescribes a standard dose of digoxin.
Exactly. And the kidneys just can't clear that standard dose, so the digoxin starts building up in the bloodstream day after day.
And what happens to the patient?
Eventually, they develop severe toxicity. They start experiencing profound nausea. Their vision might become blurred or tinted yellow.
Yellow vision.
Yeah, and ironically, the drug causes dangerous, life-threatening heart arrhythmias, the very thing it was supposed to help manage in the first place. For decades, digoxin toxicity was one of the most common reasons elderly patients ended up in the emergency room.
Okay, hold on. When I think of an older person ending up in the ER from a severe adverse drug event, I naturally assume it's because they're taking some heavy-duty, complex medications.
Sure, that makes sense.
Like, I'm picturing aggressive chemotherapy agents
Right.
or maybe weird experimental psychiatric drugs. Is that what is actually driving these hospitalizations today?
It is entirely logical to assume that the most powerful drugs cause the most harm, but there was a landmark 2011 study by Dr. Dan Budnitz, published in the New England Journal of Medicine, that completely upended that assumption.
Really? What do they find?
His team analyzed nationally representative surveillance data for adverse drug events in older adults, expecting to find those exotic drugs at the top of the list. Instead, they found that nearly 2/3 of emergency hospitalizations were caused by just 4 everyday drug classes.
2/3 of ER visits from just 4 types of drugs, and they are, looking at this study here, warfarin, which is a common blood thinner,
Right.
insulins for blood sugar, oral antiplatelet agents like aspirin, and oral hypoglycemics for diabetes.
Yep.
We are talking about the most ordinary guideline-recommended drugs sitting in millions of medicine cabinets right now.
The danger lies precisely in their ubiquity. They are prescribed constantly because they are necessary to manage chronic conditions, but they require incredible precision.
Because of the aging body.
Exactly. When you put an insulin or a blood thinner into an aging body that has hidden kidney decline and a shifting volume of distribution like we talked about, the margin for error just vanishes.
The blood sugar drops too low or the blood becomes too thin.
And a routine prescription suddenly turns into a massive medical emergency.
Man, if routine medications are causing this many side effects, it creates a terrifying scenario. What happens when a patient experiences one of these drug-induced side effects, but the doctor doesn't realize it's a side effect? Like they mistake it for a brand new disease.
That scenario is formally known in the medical literature as the prescribing cascade.
The prescribing cascade.
Yeah. The concept was pioneered by researchers Paula Rochon and Jerry Gerwitz back in 1997. It basically describes a systems failure where a perfectly normal adverse drug reaction is misinterpreted as a new medical condition.
So they treat the side effect with another drug.
Right, prompting the doctor to prescribe a second drug just to treat the symptoms caused by the first.
Let's walk through the textbook example they use because I think it illustrates just how easily this happens. A patient comes in complaining of nausea, so the doctor prescribes a really common anti-nausea medication called metoclopramide.
Right. Metoclopramide works really well for nausea, but it operates on dopamine receptors, and in older adults, it frequently causes a side effect known as drug-induced Parkinsonism.
Okay, so the patient develops a resting tremor and muscle stiffness.
Exactly.
And then the patient goes back to the clinic a month later with a tremor. The doctor sees an elderly person with a tremor and stiffness, and because Parkinson's disease is so common in that demographic, they make a very reasonable but totally flawed assumption.
They diagnose the patient with Parkinson's.
Right, and then they prescribe a heavy-duty neurological drug like levodopa.
Now the patient is taking a drug for nausea they might no longer even have, and a powerful neurological drug for a disease they don't actually possess.
That's wild.
They are suffering the side effects of both medications and the underlying cause. The first pill remains entirely unaddressed.
It is exactly like playing the most frustrating game of whack-a-mole.
Oh, okay.
The doctor sees a symptom pop up and whacks it with a new pill. But every time they hit a mole, they're actually bashing the arcade machine with a hammer and breaking the internal wiring even further.
The whack-a-mole analogy is painfully accurate because when a patient is seeing a cardiologist, a rheumatologist, and a primary care doctor, and nobody is communicating with each other, that prescribing cascade can result in a patient taking 8, 10, or 12 different medications.
Which brings us to some major misconceptions about polypharmacy itself. I feel like the most common misconception is that polypharmacy just simply means taking a lot of pills.
Right.
And therefore, taking a lot of pills is inherently bad.
But the goal of geriatric pharmacology isn't just to arbitrarily throw pills in the trash. The real target is stopping inappropriate polypharmacy.
Right, because if you have a patient dealing with heart failure, severe diabetes, and maybe atrial fibrillation, giving them 8 carefully selected pills might be perfectly appropriate polypharmacy.
The clinical distinction is vital. Appropriate polypharmacy extends life. Inappropriate polypharmacy involves, unnecessary duplication or continuing a medication long after the condition it was treating has resolved.
Okay, but there is a second misconception here that is equally damaging, and it comes from well-meaning doctors. It's the idea that because older bodies are fragile, we should just automatically lower the dose of absolutely every drug we give them.
There is a famous catchphrase for that in medicine. Start low, go slow.
Sorry, Lou, go slow.
Right, and it's an excellent starting heuristic for introducing new medications. But if a doctor rigidly underdoses every treatment out of fear, they end up leaving the patient to suffer.
Like leaving severe joint pain untreated.
Yes. Or deep clinical depression or aggressive infections. They get left untreated because the doctor just assumes the frail body can't handle the cure. Geriatricians actually call this ageism in reverse.
Ageism in reverse, because you are actively harming the patient by withholding the therapeutic dose they actually need.
Exactly.
To find that perfect therapeutic dose, doctors have to calculate the cumulative toll of all these drugs. The sources spent a lot of time on something called the anticholinergic burden.
This is a huge factor.
Right. This is the cumulative effect of stacking multiple drugs that block a specific neurotransmitter. And it's not just prescription drugs, right? It includes over-the-counter allergy meds like Benadryl or common sleep aids.
The anticholinergic burden is incredibly stealthy because one drug might cause a little dry mouth, two might cause some mild constipation.
Nothing crazy.
Right. But when a patient is taking 4 or 5 drugs with anticholinergic properties, the effects really stack up. The patient becomes profoundly sedated, their cognition slows down, and they become highly confused.
And if an older patient is brought into a clinic profoundly confused and groggy, it is frighteningly easy for a doctor to misdiagnose them with dementia.
Which kicks off an entirely new prescribing cascade. It happens every single day.
So if we look at the big picture here, we have the hidden kidney failure masked by the creatinine trap. We have the expanding fat tissue holding on to sedatives for days. We have the whack-a-mole prescribing cascades and the anticholinergic burden. How does any doctor operating in a fast-paced clinic possibly manage all these variables and prescribe safely?
Well, doctors don't rely entirely on memory for this. They rely on master lists and safety tools. The most foundational of these is the Beers criteria.
The Beers criteria.
Yeah.
This was created by Dr. Mark H. Beers back in 1991, right? And it was originally designed just to protect patients in nursing homes.
Yeah. Dr. Beers noticed that nursing home residents were routinely being given medications, like those long-acting benzodiazepines we discussed, that had an incredibly poor risk-benefit ratio for frail bodies.
So he created a criteria to flag them.
Right, to flag potentially inappropriate medications. Today, it is maintained and regularly updated by the American Geriatric Society. And then in 2008, European researchers O'Mahony and Gallagher developed a similar, highly influential tool called the Stop-Start criteria.
But looking at the medical community, there seems to be a significant debate about how these tools should actually be used in practice. They call it the explicit versus implicit debate.
Yeah, that's a big discussion.
Because an explicit tool is a hard checklist, while an implicit tool relies on the doctor's real-time reasoning. Are tools like the Beers criteria just a list of banned drugs?
That is actually the most common misunderstanding of the Beers criteria. It's not a list of forbidden drugs, and it was never meant to be a blanket ban.
Okay.
It is an explicit prompt designed to make the doctor pause and evaluate the risk. The American Geriatric Society is very clear that the criteria should inform a doctor's clinical judgment, not replace it entirely.
What I found brilliant about the European Stop-Start criteria is that it didn't just focus on taking things away. The Stop-P part flags over-prescribing, obviously, but the Start part actually flags under-prescribing.
It was a massive evolution in the field. The tool recognizes that withholding a necessary blood thinner from an older patient with an irregular heartbeat simply because they are old is a failure of care.
It corrects that flawed assumption that doing less is always safer. But beneath all these guidelines, whether it's Beers or Stop-Start, there is a quiet controversy about the data itself. If you are a listener who is actively managing a parent's healthcare right now, you might feel like you're just flying blind, trying to guess how a pill will affect them.
It's scary.
It is. And based on the sources, it turns out the medical field is kind of flying blind too.
It is easily the most uncomfortable truth in geriatric pharmacology. For decades, the randomized controlled trials used to approve drugs and set dosing guidelines actively excluded older adults.
Excluded them.
Yes. If a patient was over 75 or if they had multiple chronic conditions, which, frankly, most 75-year-olds do, the trial designers wouldn't let them participate because their complex health issues made the trial data too messy.
Wait, so the very people who end up taking the majority of these medications are excluded from the trials testing if they are safe?
Yes.
We are taking pristine data from healthy 50-year-olds and blindly extrapolating it to frail 80-year-olds.
Yes.
We are basically experimenting in real time once the drug hits the market.
We really are learning as we go. We rely heavily on post-market surveillance, like that Budnitz study looking at ER visits, to figure out what these drugs actually do to older bodies in the real world.
That is mind-blowing. Tying this all together, why is mastering this messy, complex reality so critical for the medical field and really for all of us right now?
Because the demographics of the globe are shifting rapidly. People are living much longer, which means multimorbidity, living with 3, 4, or 5 chronic conditions simultaneously, is the new normal.
Right.
Adverse drug events remain one of the leading preventable causes of hospitalization for older adults. The realization that our standard tools don't always apply to older bodies has made geriatric pharmacology a massive priority today.
Which makes sense.
It is the reason why every hospital discharge now involves a rigorous medication reconciliation process and why we are seeing a massive surge in pharmacist-led deprescribing clinics.
Deprescribing, the supervised, intentional process of actively tapering and taking medications away.
Yep.
Which brings me to a final thought I want to leave you with. Building on everything we have covered today, when we imagine the future of medicine, we usually picture like a brilliant scientist in a lab discovering a miraculous new pill.
Sure.
But given everything we now know about the prescribing cascade, the creatinine trap, and the profound sensitivity of the aging body, what if the greatest medical breakthrough for the aging population in the next decade doesn't come from a new drug at all?
That's a great question.
What if the real breakthrough comes from mastering the incredibly complex art of subtracting the drugs we already have? What if the future of healing is actually about taking things away?
It requires a complete reframing of how we view health in our later years. It is no longer just about adding treatments, it's about finding that perfect balance.
The next time you walk past the kitchen counter and see that massive 7-day plastic pill organizer, you won't just see a collection of colored tablets. You'll see the metabolic burning of the liver, the hidden math of the kidneys, and a delicate biochemical balancing act. Thank you for joining us on this deep dive into geriatric pharmacology, custom tailored just for you.